It gives me a great pleasure to welcome you all to the symposium. We're thankful and honored to have with us keynote speakers in the field of mental health in Lebanon, whom will be introduced individually by my colleagues, Dr. Joanne Karam and Mrs. Ramona Nasser later on. Albus Dumbledore once said, "Happiness can be found even in the darkest of times, if one only remembers to turn on the light." And Gibran Khalil Gibran once said, "Out of suffering have emerged the strongest souls. The most massive characters are seers with scars." Our mental health, our psychological, emotional, and social well-being impacts every area of our life. Having positive mental health allows us to effectively deal with the daily stressors of life, communicate with others, make healthy decisions, and live life to its fullest. But, and there is always but, sometimes struggles can make it seem like achieving a healthy mental state impossible. This is often the case in first world countries, let alone in Lebanon, which has been since 2019 subjected to a series of economic crises affecting the Lebanese in their daily struggle for food, healthcare, education, medication, and the list goes on. Never has Lebanon nor its citizens endured such crises all in one go. This definitely necessitates joint efforts among all the parties concerned to try to identify the scale of mental health problems that the Lebanese are currently enduring, as well as to try to develop preventive measures and solutions to alleviate the impact of this ordeal. Accordingly, the School of Health Sciences at the Modern University for Business and Science thought to join these efforts by organizing this symposium. Before I leave the floor to our Dean, Professor Nina Zidan, please join me in welcoming Dr. Rabia Shimai, a practicing psychiatrist, a professor of psychiatry at St. Joseph University, and founder and head of the National Mental Health Program at the Lebanese Ministry of Public Health. He developed and currently oversees the implementation of the first National Mental Health and Substance Use Strategy 2015-2020. His contribution to mental health projects among nationals and refugees in collaboration with NGOs has been remarkable. I welcome you again to this symposium, and I now leave the floor to Dean Professor Nina Zidan. Thank you.
Thank you, Dr. Fred. In turn, I am also very pleased to welcome you, dear guest speakers and attendees, to this symposium entitled Mental Health Current Situation in Lebanon. Many studies have shown that the prevalence of mental health disorders has risen in the last years in Lebanon. Mental illness is still a taboo subject. Some people are reluctant to reveal it. Stigma, misinformation are obstacles for them. They do not talk about it. They do not receive treatment, and they struggle in silence. This symposium has been organized by our School of Health Sciences at Mhps, within the framework of the European Erasmus Plus DG Health project. It actually coincides with the mission of our school, that is to promote health and wellness among individuals, of course, and among communities. We hope that this gathering provides a valuable opportunity to highlight the positive steps that can be taken to promote mental health and well-being. Dear speakers, I'm sincerely grateful to you for your enthusiasm. When we asked you to join us, you showed a lot of enthusiasm, for your interest to share your time and expertise in the field. Thank you, Dr. Shamai, for the partnership with the National Mental Health Program at the Ministry of Public Health, for your presence with us despite your heavy schedule. My thanks and appreciation to the organizing committee, to my colleagues, our students, and to everyone for being with us today. I wish you a good and productive meeting, and definitely I wish you a good and positive mental health. Thank you.
Thank you, Professor Nina. Now, please welcome me again, Dr. Rabia Shamai. And Dr. Rabia Shamai, as introducing him earlier, He's a professor of psychiatry, and he's been doing lots of work on mental health. Dr. Rabia Shammai, the floor is yours. Thank you.
Thank you, Professor Saleh. Thank you, Professor Zaidan, for this invitation. Good evening, everyone, panelists and audience. I hesitated whether I do a presentation or whether I speak to you a bit directly. So I thought that maybe because there will be a number of presentations and technical input, that maybe it would be more appropriate if I just highlight a few points to set the context for mental health, specifically in Lebanon. So, as you may know, 1 person in 4 will experience a mental health condition in their lifetime. 1 person is lost to suicide every 40 seconds in the world. And 1% is the average of health budget allocated to mental health in low and middle income countries. Most countries have outdated custodial mental health systems where people spend their lives cut from the community and subject to human rights violation. Yet, change when it comes to mental health globally is very slow and not at the level needed. Mental health has been neglected for far too long, despite all the global efforts by UN agencies, specifically WHO, civil society actors, and mental health champions. The COVID-19 pandemic has showed beyond any doubt that mental health cannot be neglected anymore. And what's lurking behind the COVID-19 pandemic is a mental health crisis, named by some as the silent pandemic. Crises in general increase the level of stress and the prevalence of mental health conditions. Unfortunately, in Lebanon, we're experiencing multiple crises that are heavily impacting the mental health of everyone. One might argue that in such situations, we should be only focusing on resolving these crises instead of reforming the mental health system and catering for the suffering of individuals. To this, I usually respond, if you have a broken sidewalk and people are falling and breaking their legs, would you choose between fixing the sidewalk or taking people to the hospital? I don't think so. So why, when it comes to mental health, we tend to fall into the trap of a false debate around tackling social determinants on one hand or scaling up appropriate services? At the National Mental Health Program, we believe that it is our duty to advocate for addressing the social determinants impacting the mental health, whether they are economic, educational, political, gender-related, or other. As it is also our duty to work on reforming the mental health system in line with human rights and evidence-based, and to develop community-based mental health services that are acceptable, affordable, and close to where people live. Since its establishment in 2014 in collaboration with WHO, UNICEF, and IMC, the National Mental Health Program has been working with all stakeholders to implement a 5-year strategy, 2015-2020, to reform the mental health system. The strategy tackles different domains, ranging from reforming the laws to scaling up the services to pushing forward prevention and promotion. And here I would like to signpost also the national hotline for emotional support and suicide prevention, the Lifeline, run jointly with Embrace 1564. And I take this opportunity to invite everyone who's suffering from any distress or in need to talk or to find where are available services, please call 1564. This hotline is available from 8 p.m. to 5 a.m., 8 a.m. to 5 a.m. the next day. And now we're working currently to make it cover 24/7. And if you cannot afford to call it, do a missed call. The Lifeline will call you back. Also, we're working on a number of research studies to inform the reform and to inform the service development. And we have a domain that's very specific to Lebanon that is inclusive of 13 vulnerable groups that are in need of specific intervention, groups such as foreign domestic workers, survivors of torture, survivors of SGBV, LGBT community, displaced populations, and refugees. In 2018, the strategy underwent an external independent midterm evaluation with the support of WHO, highlighting what has been achieved and providing recommendation for the next period. The report is available on the webpage of the National Mental Health Program for those of you who are interested in learning more about that. And we're currently working with the support of WHO to relaunch a participatory process to draft the next strategy. One of the most important elements that allowed us to push forward mental health is adopting a collaborative governance model in which all partners are around the table working closely together. It gives me today great pleasure to be here with you, and I would like to grab this occasion to extend my appreciation and gratitude to Professor Nina Zaidan for this connection with MUBS, and also extend my gratitude to Professor Saleh. I had the pleasure of meeting Professor Zaidan in a different capacity a few years back, and I still have very positive memories of how much she was engaged with mental health, and I'm happy to see that this engagement continues, and we're counting hopefully together to find also ways to collaborate around pushing mental health in the future. So thank you for organizing this event, Professor Zaidan, and also all the organizing committee. And thank you for the support you're providing for mental health. And hopefully we can explore soon with also MUBS different ways to collaborate around mental health to push forward the vision of the strategy that all persons living in Lebanon will have the opportunity to enjoy the best possible mental health and well-being. Thank you.
Thank you, Dr. Shamai. We're looking forward for more collaboration, definitely at MUBS.
Thank you, Professor Shamai. And now I would like to pass the flag to my colleague, Dr. Joanne Karam, who will be introducing the next speakers. Dr. Joanne.
Good evening, everyone. This is Dr. Joanne Karam, the chairperson of the Nutrition Department. I'm very happy to start with Mrs. Edwina Zoghbe. Mrs. Edwina is the National Professional Officer for Non-Communicable Diseases and Mental Health at the World Health Organization in Lebanon. She provides support in the development and implementation of the National Mental Health Strategy, in particular the integration of mental health into primary health care, the quality rights projects, national awareness campaigns, and various capacity building for health and mental health professionals. Mrs. Edwina, the floor is yours, and please note all the questions will be asked after the third session. So if anyone has any question, please write it down and then you'll have the chance to ask it. Mrs. Edwina, the floor is yours.
Thank you, Dr. Karam, and good evening, everyone. So I'm gonna share my screen. Can you see the slides?
Yes.
Yes.
So I'll be briefly discussing mental health integration into primary care, the experience with a focus on the experience of Lebanon. And obviously this is a picture that was taken in one of the trainings in Lebanon, and obviously it was taken before the COVID pandemic. Just a second. So what is primary healthcare? So in the Al-Ma'ata Declaration back in 1978, primary healthcare was defined as the key to attainment of the goal of health for all. So it is the first level of contact for individuals and their families. It is located near people's homes and communities, and it's the closest and easiest form of care available. And mental health is seen as a central part of the values and principles of this Al-Ma'ata Declaration, from the perspective that holistic care will never be achieved until mental health is integrated into primary care. However, for mental health, Psychiatric institutions are sometimes the only form or the main form of mental health care available. And they are highly stigmatized because when the person goes to these institutions, they are oftentimes labeled as mentally ill. They are located in major cities, and therefore many people fail to seek the care that they need. So what do we mean by integration of mental health into primary care? We mean screening, identifying and managing persons with common mental health problems that are mild to moderate, such as mild depression, referring more severe cases to specialized services for services with psychiatrists or psychotherapists. We also mean providing psychosocial support and medications and raising awareness and community outreach regarding mental health topics. So integrated mental health care services are complementary with tertiary and secondary care services. What is really the rationale behind integrating mental health into primary care? As you might already know, there is a high burden associated with mental disorders in terms of mortality, morbidity, and disability. And the treatment gap is enormous. In all countries, and specifically in low to middle income countries, there's a significant gap between the prevalence of mental disorders on one hand and the number of persons receiving treatment and care on the other hand. So it's also linked to stigma, discrimination, and it really affects the person, their family, and the society as a whole. So integrating mental health into PHC is really in line with the Sustainable Development Goals. And it works on improving prevention and early detection of mental disorders in order to prevent them really needing more specialized services. It works on integrated care, so really looking at the person from a people-centered approach, from a holistic approach. It means reducing stigma for people with mental disorders and their families, and it is really provided at an affordable and cost-effective manner. So as part of WHO, what are really the resources available for integrating mental health into PHC? The Mental Health Gap Action Program, which I'm sure a lot of you already know about it, it's an approach that consists of interventions for prevention and management of priority mental, neurological, and substance use conditions. These conditions were identified in the MHGAP based on the criteria that they are of a high burden, they result in large economic costs, and they are associated with violations of human rights. For example, some examples of these conditions are suicide, epilepsy, depression, dementia, and other conditions. So here you can see on the screen the MHGAP Intervention Guide, the Mental Health Gap Action Program Intervention Guide, which is a model guide. It's evidence-based, it's clinical algorithms, it's clinical guide for the assessment and management of mental conditions in non-specialized health settings, such as primary healthcare settings. It has been used in more than 100 countries in WHO regions and translated to several languages. And as part of the Mental Health Gap Action Program package, there are several resources that are available to help program managers, clinicians, and policymakers in the integration, such as you have seen the implementation, so the intervention guide, you have seen also, here you can see the implementation operations manual, and you can see the PM+, the Thinking Healthy, the group interpersonal therapy, and other, as well as the training packages for the MHGAP, like this, for example, in the screen. So if we look a bit at the case of Lebanon very briefly, as mentioned by Dr. Shammai, mental health law in Lebanon dates from 1983. However, the program is working on updating this mental health law. And you also know about the National Mental Health Strategy, which was launched in 2015. And now it is currently being reviewed for us to launch a new strategy. And also, as mentioned, regarding prevalence, latest data indicates that around 25% of people meet the criteria for at least one of the mental disorders. Mental health, especially back in 2015, it was mostly private and centralized and skewed to specialized care. However, a lot of improvements have been done since the establishment of the program and since the launching of the strategy. I will skip this. So WHO works closely with the National Mental Health Program on implementing this National Mental Health Strategy. And it is good to note also that this strategy is aligned with the WHO Global Action Plan. And also it was launched in 2015 and it's currently receiving its final evaluation. So integrating mental health into primary care is an integral part of this strategy for Lebanon, and the WHO and the Ministry, the National Mental Health Program, are working towards integration since 2013. And this work has been following a health system strengthening approach. So if we look at the pillars of the health system, In terms of health workforce, we have done a lot of training of trainers and training sessions for primary healthcare staff. For example, for general practitioners, specialists, nurses, social workers, midwives, and also whenever possible, we have been providing support and supervision because this is an integral part of the MHGAP integration. And WHO also supports in terms of access to mental health medications at primary healthcare level. And we have worked together with the program on developing a guide for rational prescription of these mental health medications. In terms of service delivery, the MHGAP itself was adapted to the Lebanese context. And we, along with the program, of course, there was a development of the prepaid packages of mental health care based on the priority conditions identified by the MHGAP. We have developed a lot of informational and educational material that are also based on the MHGAP. And as mentioned by Dr. Shamai as well, the process of service delivery is really a lot taking into consideration this collaborative governance approach. In terms of information systems, we have also together integrated indicators to the monthly indicators that are usually shared by the primary healthcare to the Ministry of Public Health. Of course, several challenges have been really in this process of integration. Staff turnover is a major challenge, and there's really high investment needed in the training of staff and continuous training of staff and support. We have a lot of misconceptions regarding mental health. For example, during the first 3 or 4 years from conducting regular training, one of the main misconceptions that we used to always find with staff was, for example, asking about suicide will definitely prompt the person at risk to commit suicide. So we worked a lot with them to really change this misconception, and now they are more comfortable asking this question and sharing really this experience with other staff. Also, so we have the staff management the staff and the management not understanding what it takes to integrate mental health into primary care and not willing really to add tasks. And it is also to note that supervision is very essential and it's an integral part of integration, as well as having indicators on the health information system. So I just leave you with some key recommendations, WHO recommendations for integration. Really conducting good situation analysis of the primary healthcare network and the system delivery, building on existing networks of human resources. Funding is very important. Clean delineation of mental disorders, such as we did in the packages of care. Training and really retraining and supporting human resources and staff. Recruitment, of course, of new staff that are really specifically focused on mental health. Availability of medications. Support and supervision, building an effective referral system and coordination, and intersectoral approach and linkages with the community services. And I think that's it. Thank you so much for listening.
Thank you so much, Mrs. Edwina. Very informative session. Now we'll take the questions at the end after the following 2 sessions. So now moving on to the second session with Dr. Jum'a. Dr. Lamis is an associate professor in nutrition at the Department of Nutrition and Food Science at AUB in Lebanon. She's also an adjunct faculty at the North Carolina Central University and an affiliate professor at the Pennsylvania State University in the US. Her main research interests include the assessment of food and nutrition security status of vulnerable population groups, including women, children, youth, and refugees. To date, Dr. Jum'a received several academic, research, and outreach awards, including the prestigious Fulbright Scholarship, and in 2018, she was nominated as one of the World Economic Forum top scientists under the age of 40. We're very happy to have you with us, Dr. Jum'a. Whenever you're ready, the floor is yours.
Thank you, Joanne. Thank you, everyone. With all due respect, Dr. Karam and Dr. Zidan, thank you for inviting me. I hope that my camera is gonna catch up with me. Just in case there's a problem, let me know. I'm happy to stop the video until the end. Probably some of you are thinking, why food insecurity in the middle of a mental health symposium? And probably I'm preaching to the crowd that we will see that connection as we speak. But I also want to say I'm very thankful for the kind cohort of mental health experts who allowed food security nutritionists to come on board and to talk early on in this symposium. So let's get started. Why are we talking about food insecurity? Hopefully, okay, the catch up of the slides. As you know from the invitation of the Mhps symposium, as we are working on SDGs, of course, food insecurity comes at the heart of that, be it in goal number 2, where we talk about ending hunger, food insecurity, and malnutrition in its different forms, or its interlinkages with goal number 1 in terms of ending poverty. And of course, its interlinkages with goal number 3, with good health and well-being, where a lot of the work that we do in nutrition and NCD, prevention and management, and mental health care falls under goal number 3. However, I find myself always fluctuating between those different goals in my work, as well as colleagues who work with us in sustainable food systems and reduction of food waste and so on, which is in goal number 12. So definitely there's a lot of interlinkages there. What is food insecurity? Just a very brief definition by the FAO definition and by the World Food Summit, and what has been for years been used. It basically exists when all people at all time have access to safe, sufficient, and nutritious food that not only meets their dietary needs, but also their food preferences. Over the years, this definition and its pillars have evolved, and I'm going to skip going to the details of that, but there are definitely a lot of reports that have been published over the years talking about agency, talking about food security and sustainability, talking about availability, access, and the utilization aspects of food insecurity. Why are we speaking about it? Even prior to the pandemic, the food insecurity rates in the world, and I will show you in the next slide what the rates weren't looking good. We were doing some progress. Unfortunately, in 2013, 2014, we started seeing an increase in food insecurity and malnutrition globally for many reasons that could be briefly summarized here. Of course, this is not a comprehensive list. The rise in food insecurity was also very high in the MENA region, a very specifically food insecure region compared to many other regions in the world. It, of course, is myriad of factors, political, economic, environmental factors, be it climate change, environmental degradation, desertification, water shortages, in addition to the protracted wars and conflicts in our region, in addition to all the other macroeconomic factors and political factors. With the pandemic, this has been further, of course, aggravated. As we all know, the global economy was affected. Our local and regional economies were heavily affected. The Arab world was affected adversely with significant increases and remarkable increases in food insecurity rates, unfortunately. And the food systems were disrupted globally. However, of course, in Lebanon, unfortunately, the situation was worse. And as we all know, we are living with a financial crisis. We're living with compounded crises, which have only added to the burdens of food insecurity. And of course, as we go throughout this discussion, we'll probably see some of this data that we're working on in relation to mental health as well, and throughout today's symposium. So this is what I was promising in terms of what are the food insecurity rates. In fact, when we were looking at the trends, and this is based on the FAO Voices of the Hunger Project, starting 2014, there was a standardized measure that was used, and we saw that the prevalence of food insecurity was starting to rise, and that we're looking here at moderate and severe food insecurity. I'm focusing on the Middle East, as you notice here, in the Western Asia and Northern Africa, where the Arab countries are. It reached in 2020 with the pandemic 29%. This reflects millions of individuals. We're talking 153.6 million in specific in our region alone, facing moderate to severe food insecurity. And what I mean by that in brief, based on these indicators and tools, we're talking about level of people who are not able to provide food for their families, who are not able to consume food for days at end. And there are, of course, more details and questions that dive into that. But these are numbers that are stark. And these are lives and livelihoods that have been, of course, affected heavily because of the changes that we are discussing and the ongoing conflicts and wars, displacement, and pandemic repercussions. In Lebanon, unfortunately, the data from ESCO was showing us that just looking at the data between July 2019 and July 2020, we were seeing that there was a really high increase in the food prices of all foods, definitely including fruits and vegetables. You see that increase reaching to 186% in cereals and seeds and many other. And 50% at the time, according to the ESCO report, were being at risk of falling or failing to access basic food needs and falling further into poverty, according to the UNDP reports and others. FAO also and WFP reports were showing us that households facing food shortages were reaching 55% at the national average. You notice that that number is definitely higher in certain governorates and districts. The northern of Lebanon, or Akkad in particular, is one of those governorates that actually have been classically one of the most affected, underserved populations and communities. So the prevalences were actually higher than 60%. And of course, we know all that there was a devaluation in the Lebanese pound and high price inflations, and has been increasing on a regular basis, and unfortunately only plateauing on a short period of time. However, the trend was on the increase. What does that mean in terms of people's own, as I said, experience with food insecurity? We expected that the situation would affect everyone. Of course, some communities were more vulnerable than others. If we're just to look at this on the left, the chart showing us how many were experiencing or saying that they were feeling worried about not having enough food. About 50% of the Lebanese were reporting that in 2020. If we are to ask this question currently and the newer data, unfortunately, the trends are even getting higher and higher, even among the Lebanese population. When we look at the refugee population, particularly when we look at the Palestinians or the Syrian refugees that were responded to this web-based survey, the prevalence or the number of people, that were reflecting that worry and the experience of food insecurity was higher, reaching up to 75% among the Syrians. And when you look at the right of this figure, have you felt worried about not having enough food to eat in the last month? Again, the same question, but looking at it at districts, you can also see the same thing, that there are differences. Certain populations in vulnerable communities and more rural communities were facing that worry more. If you're interested in regular data that is being followed and some of the macro and microeconomic factors and looking at the different pillars of food security, I definitely encourage attendees and esteemed colleagues to check the food security portal in Lebanon, which was conducted by a number of colleagues within the food security program at AUB that I am part of. This portal on a monthly basis, there's actually updates regarding that. However, I wanted to just, before we talk just about the national data, I want to also reflect on some of the studies that we have been doing, myself and the team that I've been working with, and where are we going and what kind of projections we're looking at in the future. And maybe we can talk a little bit about interventions in the Q&A, or at least some solutions that we can think of. So prior to the pandemic, actually, more specifically in 2014 and 2015, we conducted the first national study looking at food insecurity among the Lebanese households. At the time, I was been told that there's a lot of interest and focus, and rightfully so, on food insecurity among the refugee population. And I was involved in some of these studies. However, I've been asked about why are you interested in the Lebanese household? And I think years after that, I'm happy and kind of looking back that we have started looking into food insecurity among the Lebanese households. We started in Greater Beirut, we looked at the national data as well. And we did a number of studies, as I said, throughout those years, just to focus on food insecurity and what it's looking like. Very brief, and I'm trying to go through them fast just in the interest of time. Happy to elaborate if needed, and happy to also be sharing those resources that I am presenting here with the references. When we looked at the data in 2015 and we published it, we were noticing that the prevalence of food insecurity was much higher than we expected in Greater Beirut. It was reaching about 50%, of course, ranging between mild, moderate, and severe food insecurity. And if you just look at this figure on the right, we notice that it's almost like a bimodal distribution, where you've got this food secure and almost reaching that moderate to severe food insecurity, making the other pillar, which was alarming at the time. We looked at it from a national data. We used, as I said, this is the first national study looking at the representative sample of Lebanese households with children under 18. We also found that the prevalence of food insecurity was reaching 49%, and it was definitely high in certain regions and districts more than others. The severity of food insecurity in the north of Lebanon, again, was reaching 35%. We looked in that study at also some of the coping strategies and mechanisms that households were adopting, food and non-food related coping mechanisms. And they were at the time showing us that there are trends. And of course, they were mimicking what the FAO data is showing us at global and regional levels, but they weren't much at the household level, let alone at an individual level. We did also, of course, publish other studies that looked at children. So if you're interested in that, again, we looked at trends of food insecurity among children, relationship to dietary intake, to nutritional status among mothers, its relation to obesity. But in the interest of time, I wanted to also shift and tell us a little bit about the unfortunate projections that we are seeing. And maybe I'm painting a gloomy picture here, but it's unfortunately the situation. And hopefully we can find a positive take-home message, of course, after this. The trends of food insecurity, earlier this year, we published data together with my colleagues using the Gallup World Poll data. This is the data that basically has been between the FAO Voices of Hunger project and the Gallup World Poll surveys have been doing since 2014 with the food insecurity indicator being included. And we were able to access and have license to that data. So we used that data as well as some of the income scenarios that we were looking at in Lebanon to project trends. So as researchers, you might be saying, like, why are we looking at this? We are interested in seeing pre-pandemic and pre-health and economic crises, what was going on, what were the trends? And we were seeing that if we were just by that data and how the incline was in the food insecurity, we would have been reaching 27% by 2022. However, with the health and economic crises and what's going on and continues to go on, and we saw that those trends actually were starting to increase. So what I'm presenting here is that if we look at three scenarios, if we look at 50% decrease in income, if we look at 60% or a 70% decrease in income, which are realistic scenarios, they're not, they're not actually theoretical scenarios, they're realistic because they're based on the ESCO data, UNDP data. And what we saw is that they're reaching up to 39% in the highest income reduction scenario. If we were to look at males versus females, again, just a quick snapshot, you will see that the graph or in the top is showing us among women, there are higher trends. It reaches up to 44% in terms of our projection of food insecurity. If you look at the males, it reaches maximum 35%. We had different analysis looking at gender and food insecurity in the Arab world, and it actually does show that overall or on average, there is higher food insecurity among women. And of course, this may not be a surprise to this group because we also see disparities in many other determinants of health between men and women. When we look at older adults versus, again, the younger, and this is the older cutoff here was basically greater than or equal to 45. So we're not looking just at seniors or the geriatric population. We saw that the older adult, kind of in sync with the literature, would be also at a higher risk of higher food insecurity. What this paper for us was doing is showing us projections, but also highlighting who are the groups that need the most attention or the vulnerable groups that require our attention because they are going to be at most risk of food and nutrition insecurity. Fast forward to why am I talking in a mental health symposium? I have been interested actually for a couple of years now, but just recently it became more into fruition in the past year and a half to look at this intersection between food insecurity and mental health. We talk about health dimensions, but unfortunately, a lot of times we work in our own silos. And when I was interested in mental health, actually, I was looking particularly at college population. And this study was pushed up until the pandemic and post-Beirut port blast. Unfortunately, we were able to conduct it in January, in the spring of 2021. And these are just preliminary findings based on the master's thesis student Rita Aitani, who worked on this, and I give her a big shout out because she really worked hard on recruitment at a time when maybe not a lot of people were interested in being engaged in research. Our preliminary findings, let me just jump in here to the result. We found out that food insecurity is actually prevalent among college students in Lebanon. We had university students from the Lebanese University and from private universities like AUB, LAU, Balamand, LIU, and a few others. We found out that 61% at the time were reporting food security, the green figure, whereas the remaining were reporting different levels of food insecurity. Again, if you make college students, they're not representative of the other, group of students who are not necessarily attending school. So this is going to be of a more or less, higher educational level group. So imagine when we look at the national data, what that would reflect. What we found interesting and unfortunately stark is when we looked at the mental health parameters, and we just looked at three basically in the study. First was looking at the results from the patient health questionnaire, or the PHQ-9, which was validated among this age group. And we found out that actually the 23% were severe, were reporting severe depression. And if we combine the severe, the moderately severe, and the moderate depression, we're basically reaching and exceeding 50%. If we look at general anxiety disorder, we also saw that those are alarming figures. And again, this is something that for me as a nutritionist, as a non-mental health expert, if I may say, I was looking at this data being very critical and looking whether this is something that is being echoed in other populations. And we saw that the depression levels were definitely increasing compared to other college students, studies published in Lebanon and also other countries and other settings. When it comes to food insecurity, we were in kind of in sync with what the data is showing us in other countries, although the studies are relatively limited in the MENA region. Most of these studies were done in more of higher income countries, particularly the US and Northern America. When we looked at some of those associations with food insecurity, what we expected is with education, you would have a lower, if there's a parental educational level, university degree or higher, there would be lower risk of food insecurity. However, when we asked about the stress levels, they were associated with higher risk of those of food insecurity, and income. The higher the income, the lower the risk of food insecurity. When we looked at the associations with mental health parameters, what we did find is also something we could expect, but this is the first time that we are documenting it, is that those who are food insecure are more likely to have higher scores of PHQ-9 and GAD-7, and a higher score would basically reflect higher levels of mental health, I wouldn't say disorders, but higher anxiety and higher depression levels. And with WHO-5, we saw that the trend is with higher food insecurity, you have lower risk of, scores on WHO-5, which is also a continuous variable, but this one, it's in the other direction. So the higher scores of WHO-5 usually mean better well-being, lower, that association was also kind of in the right direction. Where do we go from with this next? We actually are currently working with Mhps, with Dr. Joan Karam, and with Dr. Pascal Salimi from the Lebanese University, and with Dr. Miray Serhan and others on a national study looking at the food insecurity and the mental health and other socioeconomic and financial parameters. And we have actually reached, Joan, correct me if I'm wrong, 352 participants so far. This is the QR code for those of you who are interested to help us out in increasing our sample size, reaching out to more people from different governors across the country, because we want to look at the national figures and see some of those trends. The hope is, of course, that there would be some recommendations and interventions, like all our studies and our publications. What would be the implications of such work is to feed into national programs that may help with the excellent campaign that the Ministry of Public Health and WHO are working on. Unfortunately, in food insecurity, the situation is way more fragmented. We do not have a national strategy, and there's much to be learned from your work. Big thank you to all the people who I'm working with on different projects, including those that I have not talked about today. This is not an exhaustive list. But finally, I want to just end with this, and I really hope I'm not eating into the time of Dr. Lillian. But I want to end with this that I saw today on a friend's Facebook basically profile, who was basically featuring her daughter's writing about mental health in Lebanon and how it is a social burden. Unfortunately, a lot of the times the interventions that we do may be individually sought. And I thought that this echoes a lot of what happens at the level of food security, where families are trying to find their own ways to live, coping in their own way, and there aren't really national strategies to support us. And I just thought that this is something to keep in mind, is when we are thinking about those recommendations, that we don't just do patchwork, which unfortunately in our setting, in our context, that's how many times we've been forced to kind of think like that. And with that, I just want to thank you and appreciate again the opportunity of talking today.
Thank you so much, Dr. Lamis. You're right, we reached so far 352 participants in the survey. So I'll be sharing the QR code again at the end of all the symposium. And this way, whoever is interested, we would appreciate really if you can fill the survey, it would be of great help for us. And moving on, thank you again, Dr. Lamis. Moving on to the third session with Dr. Lilian Ghandour. And by the way, don't worry, we're on track. So the session with Dr. Lilian Ghandour, she's a tenured associate professor at the Department of Epidemiology and Population Health at the AUB. Over the past 2 decades, Dr. Ghandour has been involved in the design and analysis of various national and international surveys on youth mental health and substance use epidemiology. Dr. Ghandour has secured numerous extramural research grants and received various awards for her research on youth mental health, which she conducts in an inclusive, multidisciplinary, team-based collaborative approach. Dr. Ghandour, the floor is yours whenever you're ready.
Thank you, Dr. Karam. Let me just make sure that my slides are working. So,
we can see
it. Does it show in slide view?
Yeah, we can see it.
Okay, perfect. All right. So I want to thank Professor Nina Zaidan and Dr. Saleh and Dr. Karam for the invitation, and also my colleague, Dr. Lamir Jum'a, who made that connection with the team. And I am very happy to be sharing with you. Actually, this is the first time we are sharing these data in a public forum. So I'm really looking forward to your questions, your input, your feedback, and any questions that you may have. So as the title denotes, I'm going to be talking a little bit about the mental health and substance use in the wake of Lebanon's multiple crises. We've heard that over and over tonight. We've called it, multiple crises, compounding crisis. And I'm going to talk a little bit about the research and practice implications of the survey findings that we have had. So quite quickly, just a brief background on the crises, the mental health and substance use situation or data that we've had before the crises, mental health and substance use assessment surveys that we've conducted in 2020 and 2021, briefly describing the methods to keep in mind when we are interpreting the findings, definitely talking about some of the limitations and offsetting strengths, summarizing the main take-home points, and definitely thinking about together about some next steps and future action plans. I'm not sure why it's moving on its own. Okay. Not sure why it's moving.
Lillian, I'm sorry to interrupt. I think what happened is we're seeing your two slides. So if you want to try again to go to the slide.
Okay. Thanks, Denise. Okay. So let's see. Does it work now?
Yes, now we can see the whole screen.
Perfect. Thank you. So I'm not going to preach to the choir. We've been through a lot in the past 2 years. We've started with the revolution and then followed by the economic and financial crisis that the World Bank has characterized as possibly being among the top 10 to top 3 most severe crises globally since the mid-19th century. That's not one of the groundbreaking records that I would have liked us to reach. It's been, the COVID pandemic has had a lot of health repercussions. Definitely the intermittent lockdowns and the closures that have taken place has definitely left a toll on people's mental health. And the last straw was really the port of the Beirut explosion at the port on August the 4th, which left many injured, deceased and displaced, and many of us affected, and given the lack of justice and disclosure to the state. So with that in mind, I will start today's talk, briefly starting with what we know about mental health well-being. I know my colleague Edwina has presented some of these percentages, but just to reiterate, basically, the first and only national mental health survey that has taken place in the country is the one that we conducted while I was working still at IDRAK. It's the Lebanon chapter of the National Mental Health Surveys. It took place in 2003. So despite the publications that have come out in more recent years, the data actually pertains back to 2003. Back when we found that 1 in 4 in Lebanese adults actually suffered from any psychiatric disorder or in their lifetime. And more importantly, we found that there are substantial delays in seeking treatment. In 2012, we did the first wasn't national representative, it was a representative sample of residents of the greater Beirut area. My colleague and I, Dr. Malou from the psychiatry department, and we found that the 30-day prevalence of any psychiatric disorder was 26% in children and adolescents. And I'd like to stop here and say, this was a very extensive diagnostic assessment of mental health where 2 people would actually go through very extensive algorithms. So this was actually an let's say, not an overestimation, but possibly an underestimation of the situation. But this was a 30-day prevalence. But more alarming is the percentage that had reported seeking professional help. So this is 6% among the 26%. So a very a small proportion of people, young people affected, were actually seeking treatment for their health. And this was actually alluded to by Dr. Shamai, who talked about the treatment gap that is not just national, but also global in nature. In 2018, we reran the study, we rolled it out to the entire nation. So we conducted the study nationwide, and we found that 1 in 3 children and adolescents, and by children and adolescents, I mean 11 to 18-year-old, they screened positive for at least one psychiatric disorder. And again, despite the change in time and despite the change in samples, we see that only 5% report ever seeking professional mental health. So there's a huge mental health gap reported. I am not sure what's going on. Okay, I don't know why this is keeps moving. Okay. What do we know about? So there might be actually internal. Wait, that means sorry for the technical. I'm gonna stop sharing, and I think there might be an issue with the time. There might be a time. Where is the?
Lillian, I hate to jump in. I just was thinking, do you want to remove the slideshow and just
Yes, that's exactly
go
what I was
through
going
it?
to do.
Yeah,
That's exactly what I was going to do.
we're teachers. We love to, you know, preach
So
about
in
things
times
that
of
everyone.
crises, you improvise. That's exactly what I wanted to do. Thanks, Lenis. Okay, because I think there might be some something going on there. Okay, so but you can still see quite clearly, correct? Yes. Okay. So, and in terms of substance use, I mean, if we go back to the substance use strategy that Dr. Shamai talked about, it clearly says that there are no statistics or estimates of the total number of users of substances in the country. But we have a lot of data from ad hoc surveys. You know, the WHO and CDC, and in collaboration with the Ministry of Higher Education, they conduct the GSHS every 5 years approximately. And when we ran the analysis on the 2005 and 2011 data, we found that really there was significant rise in alcohol drinking among middle school students. And it was more so among the females. So there was a narrowing in the gender gap, not because males were drinking less, but because women aged 13 to 15, actually, not even women, females, young little girls, were actually drinking more so over time. Another study, more from the general population by Yazbek et al. Found that 11% or 1 in 10 of Lebanese adults were experiencing alcohol use disorders in the community. And more recently, we looked at cannabis use for recreational and medicinal purposes, and we found that really a substantial number of 18 to 24-year-olds were also using cannabis without any physician's supervision or advice. So what did we? What do we know now after the crisis? So let's just briefly talk a little bit about the sources of the data. We conducted 3 studies so far. So the first 2 were really twin studies. One was among the adult sample, and the second one was the child component. These were this was a collaborative effort between the Department of Epidemiology and the Department of Psychiatry at UBMC. And together we conducted an online survey among adults and children to assess the impact of the Beirut explosion on the mental health of adults and children. The third study actually was inspired by second-year medical students at UBMC that I supervised. They wanted to look at the impact of the multiple different stressors on changes in substance use patterns, and that's the third study that I'm going to be reporting on. So again, just quite quickly, the first study on adults was an online survey because there was the pandemic. We couldn't do much except doing an online survey. It targeted adults exposed to the explosion on August the 4th. And we kept the definition of exposure quite broad, and we followed the DSM-5 definition of exposure, which could include simply witnessing or hearing about others being affected due to the blast. We sent out the Lime survey link in both English and Arabic, and we tried as much as possible to recruit a diverse sample. This took place in October of 2020, which is 75 days following the blast. And we used validated Arabic scales, the PHQ-9 for depression and the PCL-5 for PTSD. We recruited around 2,000 adults. The majority were females. This is good to keep in mind. It was a highly educated sample, I would say, because 37% had held a BS or a BA and 33.5% had a postgraduate degree. And more or less, I would say a middle to upper class, if these classes do still exist, because they reported that 47% almost reported being a little bit or a lot richer than others. The second study among the children and adolescents, the other twin component took place in November, December 2020, so a month after. Consenting parents completed the survey for up to 4 children in their family. Again, we asked about depression, anxiety, and PTSD. This sample was slightly different in sociodemographic. The sociodemographic profile was slightly different in the sense that it had 50% female respondents, so the mothers were more likely to be the respondents, but we had fathers too. And also the children, so the parents reported that only 21% reported being a little bit or a lot richer than others, compared to the 40% that we saw in the adult sample. The third survey was also an online survey. This took place in March 2021. We asked about substance use changes between March 2020 and March 2021, but we also assessed stress. We assessed COVID-related anxiety, we assessed depression, and we assessed anxiety. We had 632 adults 18 plus. 45% of the samples, so around 300, were 18 to 24. And basically, again, an educated sample, you can see that the majority had either a BS or a higher degree. And in terms of indicators of financial status, this sample looked like study 1, where about 40% reported being a little bit or a lot richer than others. So I think now you're quite interested in hearing the findings, so let's jump in, just jump right in. Okay, so this is quite interesting, and I'm really thankful for the opportunity to triangulate some of the data from these 3 different findings. We tend to think about these studies in silos, but given that I was asked to present today, it's really, I'm very happy to have looked at these results quite together and triangulate, because what is quite interesting is that this study was conducted in October 2020, and a few months later, in March 2021, we conducted another online survey among adults. So both among adults, both around 70% female, and both about, more or less same education level and same financial status level as reported by the participants. And you can see how remarkably consistent the percentages are. So if you look at, for example, no depression, it's 19% among study 1 and 21% among study 3, which means that around 80% of both samples report any kind of depression. Granted that, of course, the severely depressed to moderately severely depressed are around 26 in study 1 and around 29 in starking resemblance between 2 different studies, which for me as an epidemiologist really speaks to the validity maybe of the findings, and despite the non-generalizability of the findings. The second finding was related to PTSD. So this is again among the adults. This is again to remind you, this is 75 days later after the port explosion, and we found that 1 in 3 were screened for PTSD. In March 2021, when we asked about stress and we asked about anxiety, and these are using validated scales that showed high internal consistency reliability in the sample, we find that actually, 58% were screened with high stress levels, and also, a high percentage were around 35% were screened with severe anxiety levels. A lot, but not unexpected, but quite verified by quantitative data. What about young adults aged 18 to 24? You can see that the stress and the depression and the anxiety has not spared this young, I would say, aspiring young population in Lebanon. When we looked at children and adolescents, and these are 8 to 17-year-olds, so now we're talking about a much smaller, younger actually group. We screened for, the reason we have probable there is because these screeners, basically the Scared, Price 13, and the MFQ, are really screened for such conditions, and they don't diagnose such conditions. But you can see that, again, even the youngest of the segments of the population are also sadly, anxious and traumatized, and also, 1 in 3 were screened with probable depression. Now, when we looked at the impact of the blast on mental health, let's take a moment to look at this graph. So the PTSD in the adults, to remind you, was around 30%. So remember, it was 1 in 3, okay? But let's take a look at the percentages according to the proximity to the Beirut blast site. So I can't seem to find okay, so there you go. So I mean, living closest, the people who were closest to the explosion had higher percentages of PTSD, a larger sample was screened with PTSD, closer to the Beirut site. So you can see that as you went further away, the percentage of PTSD, became lower. However, it is important to note that it did not go down to zero. It was still 30%, which means that the impact of this blast, transcended boundaries, transcended physical boundaries, and even people that were outside Beirut, reported being outside Beirut or even outside Lebanon, were affected and were actually traumatized. This is the same idea with, so we're looking at depression also, we can see, so District 1 is the Pour, Mdawar, Ermel, and Saifi. So these are the areas that were closest to the explosion site. So you can see the further you move away from the explosion site, the lower the odds of experiencing severe depression. So again, those that were closest to the site were more likely to experience depression according to the PHQ-9. Other predictors, obviously, this is again very intuitive, but again, this is data showing this, experiencing personal injuries, having a family or friend killed, having your house totally damaged, and also, displacement were related to both depression and PTSD in this adult sample. Quite interestingly, being involved in donations and campaigning and fundraising was a protective factor, meaning that you had a lesser odds of depression if you campaigned and if you donated. But again, this is a cross-sectional survey, so I don't know whether it is really the donation that is reducing your risk of depression, or the fact that you are, because you're only mildly depressed, that you are actually involved in such activities. Again, with PTSD, it's the same: proximity to the blast, injury to self, having a family member injured, and this is all in view and in line with published studies that have looked at the impact of disasters, whether natural or man-made, globally. Now, I wanted to highlight again the issue with the treatment gap. Now, when we ask children and adolescents, when we ask the parents, whether the child or the adolescent sought help after the Beirut port explosion, you can see that only 16.7% sought professional help. Those who did were thankfully the ones that had higher odds of depression, anxiety, and PTSD. So children with depression, anxiety, and PTSD were the ones more likely to seek professional help. That wasn't the case for adults. In adults, 11%, so again, a very similar percentage, right? So it's 16% among the children and adolescents, and around 12% among the adults. But among the adults, only in the case of PTSD, so only those who suffered PTSD were more likely to seek professional help, but those suffering from depression were equally likely not to. So this is something also to highlight, in the sense that, there is depression, possibly whether mild, moderate, or moderately severe, that remains unrecognized and untreated. What about substance use, which is, our latest study from March 2021? Let me just walk you through what we asked. We asked people to tell us whether, typical to what they normally consume, whether they feel that their use of alcohol, cannabis, any tobacco product, or psychoactive prescription drug has decreased, increased, or stayed the same. And we also gave them the option of saying that they've started using this year. So the very first time they've actually tried the substance was this past year. And so we combined initiation and increase together. And I'm reporting here the percentages within for each substance use category. So let's just take a look at the 18 plus. This means that among those who reported using cannabis in the past year, 47% reported increasing their cannabis use, whether in terms of frequency or amount. Let's take alcohol, for example. So among the users of alcohol, so these are alcohol users, 30% reported an increase in alcohol use in the preceding year. And same for tobacco. And we asked for e-cigarettes, cigarettes, hookah, and all separately. But for the purpose of the presentation, I chose to report on any tobacco and any prescription medication. Again, what I really want to highlight here is the relationship between stress, depression, anxiety, and substance use. I mean, if one were to make up this data, you cannot make up those response relationship. Take a look at this data here. So what this is basically showing that among those who reported low levels of stress, 4% reported an increase in alcohol use. But among those who reported or were screened with moderate stress, it was 17%. And among those who were screened with high levels of stress, it was 24%. Same for cannabis, same for tobacco, and same for prescription medication use. What does this mean? The higher levels of stress, the higher the likelihood of increasing your substance use. Same for depression. I will let the data speak for itself. This is the data. So among those with no depression, it was 8% for alcohol, mild depression 16, moderate 20, moderately severe 25, and severe. And these are all statistically significant for those who are wondering whether the p-value is less than 0.05 or not. And finally, when we talk about anxiety, same. The data is speaking for itself. A clear dose-response relationship between increased levels of anxiety and increased likelihood of substance use. When we look at perceived SES, so this is, when they reported whether they were a little or a lot poorer or about the same or a little or a lot richer, we see that actually those who see themselves as a little or a lot richer are the ones who are reporting a higher percentage of initiation and or increase. So you can see that the percentages were higher among those who saw themselves as either little or a lot richer than others. Okay, so what is the summary? Basically, let me just start saying that we are very much aware about the limitations of these surveys. Non-probability convenience samples are not generalizable. Online surveys may leave out people with limited web literacy. None of the studies actually targeted or focused the more vulnerable populations, such as refugees. We did not look at the impact of parental mental health on offspring mental health, which I'm assuming is a big area of research. The absence of national baseline estimates impedes you from doing pre-post comparisons. So there's nothing to read, there's no benchmark to compare to. The benchmark dates back to 2003, which is almost 18 years ago. Delays in securing ethical approvals and funding delays obviously or delay adequate post-crisis assessments. So the crisis happens in August. By the time you put in the proposal, you get it funded, you get IRB approval, you're already 3 months down the line. And I see Dr. Jum'a smiling because, again, doing things ethically and in a proper way, obviously sometimes is not so research conducive. And finally, it was very difficult to disentangle the independent effects, but that was not really a major research objective of mine. I wasn't trying to look at which stressor was more important than the other. I just wanted to verify using quantitative data all the notions that we've had as individuals living in Lebanon. But in epidemics, right, in communicable diseases and infectious diseases, one case can create an outbreak. So why isn't it the case for mental health? So regardless of whether these are nationally representative surveys, the fact that you have 1 in 3 people who have answered these questions are suffering from depression, severe depression, and a very, very minimal, small percentage of them are seeking care, that to me is enough data to do something about it, regardless of whether they are representing the general population or not. And it is a relatively diverse participant, so there is much to do in that sense. So what do we take home from these data? That the impact of the blast is huge. Even the sound and sight were witnessed miles away, so in terms of PTSD rates. There is a high burden of mental health problems in all age groups, both young and old. Substantial increases in alcohol, tobacco, and cannabis and prescription drugs comorbid with mental health suggest that maybe people are using these as negative coping strategies and that we need to provide them with more healthier alternatives. There is a clear need, and I echo Dr. Shammai's point that there is always a clear need for making sure that we have accessible, equitable, and age-appropriate services, but also disaster response strategy. I mean, in this part of the world, disasters are not so rare, right? I mean, we are always suffering some kind of crisis. And I know for a fact that the National Mental Health Program and strategy was built following the Syrian refugee crisis, and they insisted on making it, a strategy that is relevant to all residents of Lebanon, regardless of age and nationality. So I think there's a huge need to make sure that we are proactive and ready for such events in the future. I know that there was, I stole these slides from a previous presentation that Dr. Shammai had given in one of my classes. The Rationale mental health program really has been doing a lot pre-crisis, starting with the Syrian crisis. And I know they did a lot in terms of the COVID and the blast response, but there's really a lot that we can still do collaboratively, all of us together. And I'm really happy to be speaking here today to a diverse group of people because there's so much we can do. And Rabia knows we always try to engage in research that is always translatable to policy and practice and actionable. We could roll out potentially, there are success stories from school-based interventions that we've conducted to improve emotional resilience among young people. This is fresh from the oven, from the Wellcome Trust. It says what science has shown to help young people with anxiety and depression just came out in 20 October. So I invite people to look through it, some really interesting reviews. And last but not least, I want to stress and reiterate on the importance of data. Data, not ad hoc data, not online surveys that happen post a particular crisis or post a particular event. I think we really need to have, just like the epidemiological surveillance unit for communicable diseases, I really think we need to have a surveillance, a mental health surveillance system, or a mental health repository where data is collected on a continuous basis in order for us not just to to analyze the data, but also to see the impact of crises, but also the impact of interventions and small scale and large scale interventions. So I would say research evidence, strategic planning and priority setting. Yes, I would like to highlight this point. Post the blast, a lot of us actually just individually ran into this and tried to collect the data. And I really think that there needs to be a strategic way of coming together as mental health researchers and figuring out who does what in such times, just to avoid duplication and overburdening the affected population. So these people that were affected by the blast, they were interviewed over and over and over again by multiple different researchers for the sake of research. But I think more strategically planning for this would result in more effective outcomes. Definitely continued strengthening interministerial coordination, but also public-private partnerships are very, very much important. And finally, I think we need implementation research, which just basically tells you that all of these NGOs, they just went down to the field and did a lot, beautiful work by the NGOs, but there is a need to also evaluate the feasibility, accessibility, acceptability, and impact of these interventions, just to be more prepared for any future similar events. And with that, I thank you for the invitation, and I hope I did not take too long.
Thank you so much, Dr. Lilian. Thank you for sharing this very interesting data, yet alarming data. So we hope by collaborating all together, we can really come up with new strategies, new solutions to make an impact, because this is why we're here and this is why we're holding the symposium today. So thank you again. Now moving on to the questions, we'll have almost 5 minutes for questions for sessions 1, 2, 3. So please, if you have any questions, you can ask.
We couldn't have been this clear.
Yeah. Okay, we have.
I think the numbers were stark, Lilian. I think you left us with a lot of numbers to ponder over. Yeah. It was a wake-up call, but I think Dr. Shamai has a question.
Yes, thank you, Edwina, Lilian, and Lamis for these presentations. I mean, I think it's a beautiful link between policy and the work of normative long-term health system strengthening, and how we should respond, and then how research actually can inform that. And I know that we've been talking and collaborating with Lilian in particular for a few years now, but I agree with you that we can do better, and we can do better intersectorally also. I mean, as shown with the presentation from Dr. Juma. So I just want to say that I'm taking home a message to properly think about how we can move research on a national level, and as a program actually within our new structure, internal structure. Now we have a unit that we started around research and monitoring and evaluation, with the aim effectively of synergizing nationally what's happening, and also collecting some data. I mean, these discussions we've been having with WHO for so long. I mean, we know from experience what are the needs, what's happening, what are the prevalence, but yet we're struggling to collect routine data in mental health. Now we had this huge step of integrating a few indicators that are going to be collected regularly, that to which Edwina has pointed in her presentation in case it was missed out. So we're moving forward, but not at the speed needed. So point taken, and hopefully we can continue this discussion after this symposium. Over.
Thank you so much, Dr. Rabi. There's a question to you, Dr. Juma, from student Marwa Riman. She's asking, how can everyone from his house battle food insecurity?
Very good question and very interesting question. I think, can I flip the answer? I think that it is not an individual responsibility. It is a collective responsibility. And this is what I was meaning when I was looking at the mental health quote from today's excerpt or article, that if we look at it as an individual problem, it will be, and we always individualize it, it's only those families that have children, or it's only families that are refugees or migrants, and it will always become them, their problem, and there will be no national, ownership of this or governance. And I think we have one of the missing points here is, let's start that we don't have a national strategy on food insecurity or food security for that matter. It's owned by different people. There's the Ministry of Agriculture that tries to go out and work on food availability dimensions. And there's, of course, excellent work done by FAO with partners, WFP and UNHCR, when it comes to specific refugee populations and pockets of poverty and working with vulnerable Lebanese communities, but it isn't owned by the national, there's no governance to that. So I want to say that there's where we have to start. But in the meantime, where can we also be doing? What can we be doing? And I am very much of an advocate of community work, and I don't believe only that the policy work will be the only way to go about it. To quick answer this, there are farmers markets, there are community kitchens, there are different ways to actually access food, because we don't want us to access ultra-processed, energy-dense, nutrient-poor, and cheap food, because that's going to get me to the paradox of food insecurity and obesity. And we're going to end up with NCDs, and we're going to end up with, from malnutrition to deficiencies that we're going to cost us a lot as a health system and as individuals. As households, I think we're trying to see about, there are a lot of projects that are happening now, again, by WFP, UNHCR, through the school feeding programs that tackle public schools, that tackle not just the refugee population, but the vulnerable Lebanese households. School nutrition is very important. I'm a big advocate of that. When it comes to household level, there are a lot of NGOs that are trying to do this kind of work. Actually, we did work just before the Beirut port blast, looking at food aid distribution in the country and how that is looking in terms of nutrition and dietary diversity. And unfortunately, the data is not showing that the food aid that is being distributed with all the goodwill and with all the good, that comes with it, it's not actually well designed, because again, there's no ownership by the government as to what is being distributed. And NGOs are trying to work, and sometimes it's personal initiatives. They basically pop up and then they die in no time, because it's just trying to serve a need. But what happens is you end up with infiltration. You end up with infant formulas being distributed, which I know the Ministry of Public Health is working really hard on combating that, and in a positive way, through IYCF, through infant young child feeding practices, through like Hamli al-Watani. WHO has been doing in the past 2 weeks, great videos on breastfeeding, on the importance of continued breastfeeding, on what is the right complementary feeding. So these are things that people should be aware of. There are hotlines, by the way, like with mental health, which I really salute, and I was writing the number again for anyone who is interested in it. There are also hotlines for breastfeeding. And there's a hotline actually for those who are interested in free counseling in order to help, especially with families with young children less than 2. We don't want the future generation to be suffering from malnutrition. And unfortunately, the UNICEF report in the past year showed that for the first time, we're starting to see food insecurity and malnutrition among young children. And particularly, we're looking at, and there's a SMART survey now currently being done. The results are going to be out soon to show us if there's stunting, if there's wasting, things that we didn't expect to see in Lebanon again. So with families with young children, there are Hamlet Wataniye, national campaigns. If we talk about food aid, just being careful about that. Unfortunately, in the lack of a good governance in terms of what food is being distributed and the cash transfers that are not necessarily done properly, I don't have anything to say at this point on that. And making sure that we continue to think about different livelihoods and coping mechanisms that are not just non-food related. So depending on remittances is one thing. One of the things about the resilience of the Lebanese population is we continue to think about alternate mechanisms. Alternate mechanisms basically doing different jobs. And I say that with caution because there's people who cannot do those extra jobs and there might not be necessarily all the skills that are needed. There is no one solution. I will have to stop just because I don't want to take over from any other questions or from the future, from the follow-up questions, but I am happy to discuss with that person because we do have some data that can help them. If they're doing any kind of specific work, we're happy. And I believe in initiatives that are done at the university level as well, if people are interested in discussing that, not just at the household level, even within our own communities.
Thank you so much, Dr. Lamis. We'll take just one more question due to time constraints from our colleague, Dr. Sonia. She's asking Dr. Ghandour, while sharing the surveys with participants, how would participants know whether they're suffering from mild or severe depression, or if they are traumatized or not?
Okay, so that's an excellent question, actually, and I had prepared, to share with you the scales that, let me just see if there's, okay. So we did not ask the individuals about whether they were stressed or whether they were depressed or whether they were anxious. What we did is we administered validated scales. Validated means that these scales have been developed in the Western world, but they have been translated and adapted to the Lebanese context, and they've been to Arabic, and they've been used multiple times. And I see that my colleague also Lamis had used the exact same scales, this PHQ-9 and the GAG-7. And I know for a fact that also the ministry and in the PHCs, we tend to use either the PHQ-2 or the PHQ-9. So these have been validated within the Lebanese context over and over. What do we mean by validated? It means that basically the scale or the set of questions are really measuring or capturing what they are supposed to be measuring. So in the case of PHQ-9, there are 9 questions that ask about symptoms of depression. So they ask about appetite, they ask about sleep, they ask about a loss of interest in activities. So the symptoms, the signs and symptoms of depression. And then based on the answers of these individuals, we calculate a score. And that score ends up being categorized into based on worldwide cutoff points, again, that have been validated within the Lebanese context. Whether someone is actually not depressed, mildly depressed, moderately depressed, or severely depressed. Same for the PSS-10, which is again a scale. So I can show you here quite quickly. For example, this is the perceived stress scale. You've got, I'm not sure if you can see, but there are 10 different. You can see. Let me see if you can see that.
That's fine. They can contact you because we're out of time. Okay.
Yeah, so you can see that there are 10 different items. And so once you have, the answers, you can add them up and then you can categorize. So this is a very good question because in terms of validity, we cannot depend on asking people whether they are depressed or not. We have to administer validated scales to make sure that we are really truly capturing depression or any other construct.
Thank you so much for all your participation and all your questions. Now we'll move with my colleague, Mrs. Ramona Nasser.
Hello, everyone. It's Ramona Nasser, the acting chairperson of the Public Health Department at Mhps. I will start by introducing Mrs. Sarah Abu Ibrahim. She's an experienced and dedicated educator whose work is focused on math and science curriculum development and design, on teacher training, and on integrating ICT into learning to leverage the digital skills among teachers and students as well. She has a master's degree in education and training and a master's degree in physical chemistry and chemistry of materials. And she's currently working at Mhps as an instructor and part of the leadership team at the education department. Ms. Sarah, the floor is yours.
Thank you, Mrs. Ramona. Thank you, Dr. Zaidan, Dr. Saleh, Dr. Karam for the invitation. I hope everyone is going well. I'm going to share my screen. So again, welcome. And welcome specifically to this session about the digital teaching methods for mental health courses. As we all know that mental health conditions are increasing worldwide. We are not going to reinvent the wheel after the great data that has been shared in the previous speeches. Around 20% of the world's children and adolescents have a mental health condition, with suicide being the second leading cause of death among 15 to 29 years old. And the two most common mental health conditions are depression and anxiety. And as we all know, mental health conditions can interfere with our normal life, such as school, work performance, relationships with family and friends, and the ability to participate in the community. So the thing is that in Lebanon, the situation is not any better. In the fifth and latest wave of the Arab Barometer, questioning about 25,000 citizens about issues regarding mental health throughout the MENA region, 30% of the Lebanese population mentioned that they often or most of the time experience stress, and 30% mentioned that often or most of the time they experience depression. And these percentages are definitely suitable to be increased because we know the effect of the pandemic and of the situation and the crisis that we are passing through. So the main question that always arises is, can we do something about it? And the answer is yes. Fortunately, it is a yes. Actually, we need to start by familiarizing ourselves by the fact that mentally, as a young adult, we are not still fully grown, even if we surpass the age of 18. So young adults aged between 18 to 29 still experience cognitive development, and this is one of the reasons why mental illness can present at this time of life. And this is one cause of why we as educators or people who are lecturing at universities must take into consideration how to tackle mental health issues in their courses. So the fact is, learning is stressing, and we all know that. Actually, the realities of standardized tests, the increasingly structured curriculum continue to build the classroom stress level. As neuroimaging research, it reveals the disturbances in the brain's learning circuits and the neurotransmitters that accompany stressful learning environments. And the neuroscientific research about learning has revealed a negative impact of stress and anxiety in learning situations. So the good thing is that when we go to the definition of the World Health Organization about mental health, it has been defined that mental health is a state of well-being in which an individual realizes his or her own abilities and can cope with the normal stresses of life, can work productively, and can be able to make contribution to his or to her community. So the simple thing is that if we can control these factors, we can have a good well-being, and such we will live with a good mental health. So the answer to that is we need to promote the social and emotional competencies among our students. So we need to depend on SEL or social emotional learning when delivering courses to our students, despite the fact what courses or what discipline we are teaching. As a matter of fact, social emotional learning is composed of 5 main components. The first one is self-awareness. It's our ability to understand our emotions, our thoughts, our values, and how these emotions, thoughts, and values influence our behavior across contexts. So this includes our capacities to recognize our strengths and limitations, and definitely with a grounded sense of confidence and purpose. The second component of SEL is self-management, which is the ability to manage our emotions, thoughts, and behaviors in different situations in order to achieve certain goals and aspirations. The third component is social awareness, which means our abilities to understand the perspective and to empathize with others. And World Health Organization and recent business reports always classify empathy as one of the most important skills that people must have in the 21st century. So I should empathize with people and others from different backgrounds, different cultures, and being in different contexts. So definitely this would include having the ability to create or to feel compassion for others, to understand why people act in a certain way based on their historical or social norms in different settings. The fourth component of SEL is relationship skills, which is our ability to establish and maintain healthy and supportive relationships, and to effectively navigate settings with diverse individuals and groups. So as we all know that in many cases, relationships end up in a very dramatic way, and this is maybe a lack of social and emotional competencies. So when talking about relationship skills, this includes our capacities to communicate clearly, to listen actively to others, to cooperate, to have the skills of teamwork, to problem solve, and to negotiate in order to solve certain conflicts. The fifth and last component of SEL is responsible decision making. It's our ability to make caring, and constructive choices about our personal behavior and about the social interactions across diverse situations. So here it includes our ability to consider what are our ethical standards, what are the ethical standards of the others, and what are the safety concerns that we should take into consideration before making any decision. So the fact that SEL is now worldwide considered. 65% of surveyed executives say that they'd rather colleges build up students' life skills instead of only academic skills. Google mentioned that 7 top characteristics of success at the company are all SEL related, such as communication, such as listening, good ability to process insights into other, also known as empathy, and like the Wall Street Journal also mentioned the importance of having such skills among employers. 92% of surveyed executives say that skills like problem solving and communicating clearly are equally or more important than technical skills, which puts us in front of a challenge that we need to make our students able to have these skills before graduating from high schools or from university level. So the top 10 skills, in addition, identified by the World Economic Forum, involve social and emotional competencies like complex problem solving, critical thinking, creativity, emotional intelligence, coordinating, and cognitive flexibility. So also regarding to the students, students find a great importance when it comes to SEL. And they say that there is a significant deficit in high schools preparing for life after school. So there is another good news, that after we mentioned the thing about SEL and that we need to incorporate SEL into our curriculum in order to make our students competent to compete in such a 21st century world, there is another good news, which is the digital tools. We know that after the pandemic, digital tools became more and more important than ever in supporting existing care and in providing scale and increasing capacity. So these digital tools may be our way into helping our students to increase their social and emotional competencies, and by so we can help them to secure a good mental health along their lives. So I'm going to share a few of the digital tools. Definitely we don't have time to cover, but we are sharing the most important. And as we all know that there are many ways to ask our students about how they are doing. So we are going to start with a very simple exercise. I'm going to kindly ask you to click on the following link on the chat and to take a few minutes of your time, few seconds, to just tell us how you are feeling. It's a very simple question, and I would like to hear from you, which is completely anonymous, by the way. And I'll be sharing my screen again. We have certain results. Oh, very nice. Let's share them. So as you can see on the screen, comfort, nice. As you can see on the screen, we have great answers: thankful, tired, anxious, stressed, positive, sleepy, a little stressed, demotivated, numb. Okay, I think it has been a long day. So it's a very simple question, yet it's very important, because this way, when asking people about how they are feeling, this is a step into discovering our own emotion. So this is a step into self-awareness, building this self-awareness, and maybe building empathy among our students. So one of the simplest digital tools that we can use in order to promote social and emotional competencies among our students is using such tools. Thank you, everyone, and the answers are pretty nice. Another question using the same link, using the same digital tool, which is Mentimeter, is that we can also have different questions like the following. When I ask students to express how they feel about each other. So we have an electrical cut, okay. When we ask students how they feel about each other. So for example, taking another question into consideration, if I may ask you, for example, now, this is a question. Imagine that we are asking yourself, what do you think of me? It's completely an anonymous question, so we won't be able to know who is answering. So this is another question that may be used to promote empathy among the students and to promote another social emotional skill, which is the ability to be socially aware and to maintain relationship skills. So we can, okay, let's share the results again. We can definitely do this practice among students who know each other for a long period of time, because this will be much effective. Oh, thank you. Thank you very much. So such results we can depend on and make our students reflect upon in order to see if they are able to communicate well what they are seeing in others, and in order to make sure that they are able to accept criticism that is shared to them. And thank you very much, everyone. I will move to another tool, which is one of the greatest, which is Google Suite. Google has a great potential there that we need to take benefits from. So for example, if I may share with you another prepared document, which is a document, a shared Google document that we can share among all the students. This is one of the simplest exercises that we can share with our students, and that we can share the document itself. So students may be able to see each other's comments. It's something called the emotional log, where we can ask our students to mention what emotion are they feeling, the intensity of this emotion, where did they feel this emotion, and what was the reason. So we have two examples here. If we were in a conflict with a colleague, how did this make me feel? Angry? Okay, where was I at this time? What day, and so on. This way we are creating the self-awareness among our students, which by result will help them into acquiring the social and emotional competencies that we are striving for. We'll move on to another website, which is one of the greatest also, and I highly encourage using it. It's called SuperBetter. Definitely using this website, we need to create an account, but I already created an account, and this website can be incorporated into our lessons, especially if you are teaching mental health courses. This website actually is based on certain challenges that we use in order to make our students reflect upon. It's a motivational app. It may be downloaded even over the phones. It has a series of games, challenges that build strength and overcome weaknesses. For example, let's go to power-ups on this website. So as you can see here, we have activities, we have requests, we have allies, we can post in here, and we can share with others. But the most important thing is this website allows us to, for example, feel the motivation and feel that we are always productive, which by result enhance our emotional level, our emotional feelings. So, for example, there is an activity here, chug of a glass water. Okay, whenever I do this, I just claim that I did this, and such I feel that I did something, I did an achievement, and this is definitely proven to be helping in improving mental health. So that's the second website, which is SuperBetter. And now we are going to another one, which is very reputable in USA, and it's gaining a lot of traction, which is called Empatico. Empatico is one of the greatest websites. As you can see that around 40,000 registered educators, over 60,000 students are participating, and over 163 countries. Unfortunately, in Lebanon, it's still a shy participation, because this may be related to the lack of awareness that we are having in Lebanon regarding social emotional competencies and regarding the mental health issues. So whenever I go to Empatico, the most amazing thing about it is that it connects classrooms. In other terms, it lets us be exposed to others' experiences in life, other concerns in life, which by result will create empathy and will create a big ability among people to understand what others are feeling or what others are going through. So here we ask to request a match with a certain class, and then whenever they accept our request, we are able to match with them, and we merge our classroom within the class that accepted our match. And then the students will have a virtual activity that will spark empathy. I highly encourage using Empatico, especially in Lebanon, so we can create this community of people who are there to support each other, starting from very young ages, because as you can see, it's not restricted to one age group. It's very diverse. We're going to move to another website, which is called the Social Express.
Ms. Sarah, I'm sorry to interrupt you.
Yes.
I believe these are very important websites you are sharing with us, but since we don't have a lot of time, maybe you can share with us the remaining website after the symposium, because we have to move to our next speaker, Dr. Mada.
Definitely. We are almost done. I'm going just to end with, there is another website related to productivity, which is links to websites where we can organize digitally our work. And one of them is Evernote. I'll be sharing them on the chat, because whenever we have a good organization, we have better time management. Better time management means better decision making. And thank you, everyone. And thank you again for this chance. And it was great meeting everyone. Thank you.
Thank you, Ms. Sarah. Thank you for the valuable info and for the websites you shared with us. And now we will move to Dr. Diana Mada. She has a PhD in public health from a joint program between the Lebanese University and American University of Beirut. She was assigned as a member of advisory committee on women leaders in global health run by Stanford University. She got many awards. She designed, delivered, and attended many local and international humanitarian workshops in London, Peru, Spain, and other countries. Diana joined the MUBS in 2016 as a public health associate professor and a research director in 2018. She is currently working as research, risk communications and community engagement health referent at UK Med. Dr. Diana, the floor is yours.
Thank you so much. And I'm so sorry if I look sleepy and tired. It's 3 a.m. my time. I'm now in a humanitarian mission in an island very close to Australia. So excuse my look and my tiredness.
Yes, so, actually, I was going to thank you, Dr. Diana, really, because we know that you are on a humanitarian mission in the middle of nowhere, in the middle of the night. What is the time now over there?
It's almost 3 a.m.
Thank you. Yeah. Really appreciate it.
Thank you so much. Thank you, Dr. Nina. Thank you, everyone. I'm so happy that I'm seeing also some of my professors from EUB with us, Dr. Lilian and other people, Mrs. Edwina, Dr. Shammai, and everyone. In this, I will be very brief. I just want to give you an idea about what are the projects that we have conducted so far at the Modern University for Business and Science related to mental health. I'll start with a story. Sorry. Moving from a place to another, searching for a home with his wife and 3 children wasn't easy because of threats and social insecurities. Khalid lived in continuous mental anguish without seeking treatment as a result of stigma and the daily routine of getting some food at the table of his family. He as well had to deal with keeping his emotions and weaknesses to himself in front of his family and social encounter until he broke down. His symptoms started with the Syrian crisis, and they were as follows: headache, vomiting, dizziness, and stomachache, in addition to his self-isolation from his family and friends. After a very long and exhausting day at work, the most frustrating thing was to see my children afraid of me. This is not the story of Khalid only. It's the story of thousands of refugees, whether in Lebanon or worldwide. So, but we have to understand that mental health is not a privilege. It's a right to everyone. It seems normal for a refugee's mental health to be provoked as circumstances and emotional consequences of moving to a new country and starting from the very beginning as a stranger with basic and urgent needs. In such cases, seeking mental health support appears to be overlooked. Till summer 2021, there are over 82.4 million displaced people and 26.4 million registered refugees worldwide. According to UNHCR, 15 to 20% of displaced people have mental health problems. Some studies verified the fact that refugees are at higher risk of suicide. Much of what is already mentioned on mental health in conflict settings applies to the case in Syria, that is leading a country of origin for refugees. So mental health problems have been identified as the third greatest health need for Syrians displaced to neighboring countries in the region behind communicable diseases and women's health. So what about Lebanon? Zooming into the case of Lebanon, the situation in Lebanon is not dissimilar. We can say it's more difficult. So knowing that Lebanon is passing through the hardships because of the recent political unrest and the economic and financial crisis, which has been amplified also by the COVID-19 pandemic, in addition to the catastrophic explosion in Beirut blast, in Beirut port, which lead also to more and more negative outcomes. So all these crises coupled with the challenges that come with being refugee caused a significant increase in extreme poverty, hunger, mental and physical health problem, in addition to child labor and gender-based violence. So moreover, research is showing that the mental distress among women who lived war and conflict is leading to negative parenting and psychological problems among their children. And that's why here I want to focus on the projects that we have conducted so far at MUBS. And definitely I will not cite all of them. I'll go through a couple of them. One of them was Empower, which was funded by EU Madad, where we were able to reach out to mothers who are living in rural communities in Lebanon, as well as Syrian refugees. We were able to conduct for them parenting sessions. And we adopted also the participatory approach in addition to the TOT approach, where we were able to allow those mothers to train other mothers and the children the same thing in their communities. So we were able to reach a higher number of beneficiaries. The same for Mother United. Mother United actually was the fruit of and like a very interesting program that was conducted and mentored and supervised by our ambitious Provost Dr. Alami, Dr. Nael Alami. We were able to have a class between the Faculty of Medicine in Stanford and Stanford University and students from MUBS and other universities as well, to have this exchange classroom, where we were able also to fund a project between, like it was funded by both MUBS and Stanford University. We were able to conduct a project called Mothers United in Bekaa Valley, in one of the refugee camps, where we were also able to train 40 mothers, Syrian mothers, about parenting skills and communication skills with their children to enhance their mental health. And also we adopted the TOT approach. In these two projects, we were able also to publish the results in academic journals in order to share best practices with other people. Also Khutwa, and here I would like to mention that I discussed that before we started this project with Dr. Shamma. I guess, I'm not sure if you still remember it, but it's about the life skills to enhance mental health among university students, and we came up with very good results. Maybe when I come back to Lebanon, we can meet Yumi and Dr. Alemi to discuss further how we can scale it up at the national level, hopefully at the international level. Also at MUBS, what we are doing is that we are encouraging our senior students to conduct their senior projects and to have research projects accordingly to be published. Recently, we're working with students who are doing a project related to the mental health of the students after the back to school strategies. And finally, I would like to say that in the last 2 years, we have conducted more than 30 seminars and health awareness about mental health in the different campuses at MUBS. So this was a very brief like a presentation about what we have done so far. And I would like to thank you all for attending again. And I will give the floor now to my colleagues, my amazing colleagues from Save the Children, to share with us also their best practices, the interventions, so we can learn from each other. Thank you again for hosting me, and sorry again for being very tired. Thank you. Over.
Thank you, Dr. Mada. We highly appreciate your participation with us today. And we will move to Ms. Joy Abi Habib. Joy is currently the mental health and psychosocial support specialist at Save the Children Lebanon and a lecturer in developmental psychology at St. Joseph University in Beirut. She has been an accredited psychologist in France since 2012. She holds a master's degree in child and adolescent psychology from the University of Edinburgh, UK, as well as a master's degree in social psychology from Paris Descartes University, France. Joy has worked in child and youth mental health and psychological care in the context of child protection, displacement, alternative care with several NGOs and institutions in Lebanon and abroad. She has also been engaged in several research initiatives with an interest in refugee mental health and ethics in mental health research. Ms. Joy, the floor is yours.
Thank you so much. And thank you for the organizers and Mhps for having us with you tonight, and for all the panelists for your very insightful talks. So we're going to briefly, my colleague Nancy and I, talk about the mental health and psychosocial support initiatives done at Save the Children. I'm going to be focusing more on the programmatic aspect, and Nancy's going to be talking more about some of the specialized services we offer. But to start with, it's important to highlight that Save the Children recognizes children's mental health and well-being as a right that is placed in parity with the right to protection, to education, to optimal health, safety, and security. So I know several of our colleagues have highlighted and shared very insightful figures regarding the current situation. We wanted to highlight also the multidimensional poverty that Lebanon is currently experiencing, with around 1 million households that are experiencing multidimensional poverty, as well as around 400,000 of these households who are currently experiencing extreme poverty. And also, as we're focusing specifically on Syrian refugees, around 90% of Syrian refugees have fallen below the line of extreme poverty. All of these figures also affect, of course, child protection concerns, and around 5.3% of Syrian refugee children between the age of 5 and 17 are engaged in child labor in 2021, which is almost a 5% increase since 2020. And we also have other unhelpful coping strategies or negative coping strategies, such as an increase in early marriage and child marriage, with 20% of Syrian refugee girls aged 15 to 19 that are married, and around 30% with no legal documentation. So all of these figures are important to highlight because they all have repercussions on the mental health of children, of caregivers, of youth, and facing all of these challenges, Save the Children internationally and in Lebanon has committed to some MHPSS commitments and has urged policy, decision makers at a global and national level to also, as well as civil society and fellow organizations, to also commit to these mental health objectives, which are increasing long-term flexible funding to MHPSS. We all heard the figures that Dr. Rabia was sharing earlier around public investment in MHPSS. Second objective is to mainstream, integrate, and coordinate inclusive and accessible MHPSS across sector. We're going to tap a bit more on the intersectoral integration of MHPSS. Acting early and across the life course, we're going to highlight also the importance of starting our interventions with younger groups and focusing on prevention as well by supporting mothers and pregnant women, and increasing access to evidence-based and community-grounded MHPSS. We have also our other colleagues such as Dr. Ghandour who highlighted the importance of that, and this is one of our commitments. And finally, investing in the workforce mental health capacity, so building capacity of our teams in mental health and well-being, but also supporting them by providing mental health and additional support to our teams and frontliners. So I'm gonna present a brief overview on some of the activities that Save the Children has been done to integrate MHPSS across various sectors. And I'd like to highlight that all of the activities have been possible thanks to several coordination mechanisms. And this is really important, such as the National Mental Health Program and other committees that are very active and that allow us to liaise with other sectors and advocate for more integration of MHPSS. So of course, I guess all of you are quite familiar with the MHPSS pyramid of interventions with the different layers. We're currently working in Lebanon. Save the Children offers support across the 4 layers of intervention, and it's important for us to strengthen this continuum of care, as well as provide cross-sectoral integration of MHPSS. Of course, the child protection is one of the sectors where we intervene, providing community-based as well as focused support and specialized services. My colleague Nancy is going to be focusing a bit more on specialized services later on. Here are some of the resources that are used at the moment. So, of course, depending on the context and on the different resources, we continuously adapt our different programs. Some of the programs here highlighted are the psychological first aid, and also this is a shout out to the National Mental Health Program, who's done an incredible job to also provide various trainings in psychological first aid with the support of the PSS committee. And we also have recently developed, so Save the Children alongside WHO, UNICEF and the MHPSS Collaborative have developed a very interesting resource that's being piloted at the moment in Lebanon, which is peer-to-peer psychological first aid. So this is an intervention that focuses on building the knowledge of youth and adolescents, as well as older children, in providing support to their peers, of course, under the mentorship and guidance of trusted adults. And this has shown a lot of, it has also been responding to the needs of the youth and children to be more included in our MHPSS responses and as actors and agents of change and of support in the community. There are other programs that I won't go much into, but I'm happy to share more information in the Q&A session. And these programs include Child and Youth Resilience Program, Healing through Education and Art, as well as home-based interventions that are held with the family, and that were very helpful, especially during the COVID pandemic. Some of the other integration across sectors includes the sector of education. We have our colleague who previously very eloquently presented all the social emotional learning and its importance. So this is of course something that's integrated in the education programs, and more focus is also being attributed now to teachers' well-being. We know how important it is to also support the teachers who are providing classes in order to support them, especially in the current context in Lebanon with all the challenges that the education system has been facing. We also know the importance of integrating MHPSS in education to improve the children's well-being, but also their overall learning and academic outcomes. In terms of other sectors such as food security and livelihood, building the capacity of staff in MHPSS, including psychological first aid and other intervention, has been key to integrating MHPSS, as well as when we're doing some the child well-being assistance. It's a program that assesses the needs of the family and supports through cash in responding to the needs of the family, but that go beyond the survival needs of the children and allow families to afford other basic needs and ensure the well-being of their children. And through this program, we also are building the capacity of staff to identify and refer to more specialized mental health services. Of course, a very important component is also the integration of MHPSS in infant and young children feeding. Our colleagues have touched on that earlier, and the importance of building the capacity of the teams. And we know that the current campaign has been also doing a very good job at advocating for that. And we know that nutritional and development outcomes for children will be increased, the attachment between caregiver and child will be increased, as well as the actual support that is provided to caregivers during the counseling sessions. Finally, integration with the shelter and WASH teams. Through the COVID pandemic, we've also had opportunities to work closely with our shelter colleagues by building their capacity in psychological first aid. We know that they're also often first responders who are supporting during the COVID pandemic, as well as after the Beirut blast, and supporting the teams by building their capacity in safely identifying and referring to child protection, MHPSS, as well as providing psychological first aid has been paramount. And finally, we've also found opportunities to also distribute MHPSS kits along with MHPSS key messages with the support of sector and WASH sectors, of course, with the appropriate capacity building. And finally, we just wanted to highlight the importance of supporting the well-being of the staff who are coming in aid to the different populations we're supporting. So in order to safeguard the quality of our services, it's extremely important to also provide mental health and well-being support to our staff. And so several initiatives have been held within Save the Children, but also through different coordination mechanisms. We've been working very closely with the PSS committee, as well as the National Mental Health Program, to survey the well-being of frontliners, as well as provide different platforms to support them. And thank you everyone so much for your time, and looking forward to the Q&A section to further develop some of these components. And my colleague Nancy will be explaining a bit more on the specialized services we're providing.
Thank you, Ms. Joy. Thank you so much. And now we will move to Ms. Nancy Abu Zaid. She is a licensed psychologist by Ministry of Public Health, works at Save the Children. She holds a double master degree in clinical psychology and educational psychology from St. Joseph's University. She has an extensive experience in working with children and adults in need of further specialized support. She works closely with the children, adults, and elderly and individuals with special needs. Beside her daily work, Nancy is currently involved in different initiatives and volunteer works. She is the affiliate of the Workplace Options London and Lebanon and MENA region. Lately, in August 2021, she led the Lebanese initiative at Kafka conference in Jordan that was rated first among the different initiatives. Ms. Nancy, the floor is yours.
So much. I don't know if you're able to see my screen.
Yes.
So can you see? Yeah, okay, amazing. So thank you for the invitation. I will go briefly to talk about the work done at Save the Children among the refugees. So the psychological intervention, the practical psychological intervention, and I'll go on the group that we support, the internal and external follow-up, the objectives of the intervention, the challenges that we're facing, and to end up by sharing some success stories. So the sessions are done mainly with children between 4 and 18 years old, and our goal is to provide the children with techniques to help them manage their emotional and psychological state and to help those children in need. The caregivers, our intervention among the caregivers is divided into sessions and recurrent meetings to help to provide them with the recommendation and the adequate tools to help them deal with their children, and also in psychoeducational sessions that rotate on different axes and to help the caregivers to understand their needs and to support them. And also we intervene with different members of the same family, and our goal is basically to activate the social support within the family members, help them cope with the situation. So mainly there are two pathways, the internal and external follow-up. The internal follow-up or intervention is done at Save the Children, and it's done through the tight collaboration between the case management team as caseworkers and as psychologists. And the purpose is to provide strategies to cope with mental health needs such as distress, symptoms of anxiety, minor symptoms of depression, fear, and so on. However, in some cases, we are referring externally, and due to the need of other specialists such as psychiatrists, general doctors, nurses, speech therapists, psychomotor therapists, and here the collaboration is done with the team of case management and the specialist. And our aim is to provide a holistic support to optimize the result of the follow-up, the children and their family. The objectives of our intervention is to provide refugees with resources to support their mental health and well-being, to strengthen the cognitive and psychological abilities to cope with the traumatic situations, such as the situation that of blast and many incidents recently, and to promote resiliency to manage various symptoms of social distress or other symptoms resulting from different situations, especially when we talk about refugees, we're talking about a population that already got into different traumatic situation that is easily triggered with instability in the country. So we're facing many challenges. I'm gonna note some of them. So the socioeconomic situation in the country is leading that assisting that we're seeing many children not going to school, facing children labor, food insecurity, children marriage, and social instability leading to insecurity, and all those factors are contributing to make our work, making our work harder, and to achieve, to inhibit the achievement of our goals. However, we can note many success stories. I'm gonna share some testimonies. So my child is able to express himself and what he wants. My daughter went back to sleeping her full night, so I enjoyed the session and felt a safe space to share, and I'm able to control all bad thoughts. So in summary, our intervention had a positive impact among the children and the caregivers, and it was reflected with our result on the field and with the testimonies of the parents. So I'll remain if you have any questions to answer them. Thank you so much again.
Thank you, Dia. Thank you so much. And now we will move to the Q&A section. So please let us know if you have any questions.
But meanwhile, I'll allow myself to share my screen for those who want to scan the QR code to fill the survey. Thank you so much. Sorry for interrupting.
Mrs. Nasser, Do you mind if I jump in? Sorry, I raised my hand just in case there are no questions coming. I just wanted to salute the work that has been shared with us by different colleagues, but particularly the last two presentations by our colleagues from Save the Children. I have to say that I was very happy and impressed with the intersectorial work that you are doing, and it kind of feeds back into what we have been discussing early on about how extensive and how comprehensive the work of mental health needs to be, but again, how complicated it can be when you add other. And I actually want to just say that 2 or 3 years ago, we were working on a grant with another organization, World Vision, actually, colleagues, on a similar project where we're integrating the mental health with the early childhood education and nutrition. And unfortunately, even though we didn't get the full funding for the proposal, it's a Wellcome Trust, a big project, and it was a competitive grant. But one of the things that I did learn is that you get to learn more about how extensive the work that the international NGOs are doing or the local organizations are doing, and that a lot of this practice is being done. We just hope that there's evidence to support those excellent case studies. So there's a lot of evidence from international settings about how this integration is working. And if you are interested in doing this kind of research or you're currently working on it, we'd love to hear from you, because I think this is much needed work, and just wanted to thank you.
Yes, thank you so much, Dr. Jama. And just to highlight, as we mentioned, one of our priorities is to focus more on evidence-based practices, especially working with children and youth. And so partnering with academic institutions is also a priority, and across different sectors in SAFE, a lot of research has been done with academic sectors. So looking forward to maybe working together after this symposium. We've had a lot of ideas that we're brewing tonight. Thank
you. So I guess we don't have any more questions. We don't have questions for this section. I would like to thank you all, our guest speakers, for sharing this valuable info with us and for making this symposium a successful one. And for sure, we are looking forward for collaboration in the future. Dr. Nina, you want to say anything before?
Yes, I would like to actually, on behalf of MUBS Provost, Dr. Alimi, on behalf of our school, the School of Health Sciences at MUBS, I would like to thank you all for taking the time to speak to us today on the very important topic of mental health, and for positive and informative presentations. There are a lot of national sporadic data, and like Dr. Shammai mentioned, it's very important to actually synergize, to coordinate the activity. Probably, maybe I can suggest it will be under the umbrella of the National Mental Health Program at the Ministry of Public Health. Thank you all again. Thank you for all who attended, all the attendees, and I wish you all a brighter tomorrow. Thank you all. Thank you. Dr. Fred, would you like to say anything?
Yes, I would like to share with you this photo while I'll be concluding. As you can see, this is a flower. I'm not sure whether it's, were you able to see that?
Not yet.
No, Dr. Fred, not yet.
Okay, so maybe I'll stop sharing that. Okay. I just wanted to, well, this is not last minute technical problem. Stop sharing. Okay. All right. Please join me in thanking our distinguished speakers, students and audience who have been with us since 5 p.m. Just to let you know, we had over 100 participants attending this symposium, so this is a very good number. Would like also to thank the School of Health Sciences at the Modern University for Business and Science for making this event possible. So Thank you, everybody. Excuse me. My last words are basically that we may conclude that economic crises are chronic stress situations, and as such are likely to have psychological and psychopathological consequences. Indeed, they can produce adaptive responses like normal sadness and dysfunctional responses like depression and suicidal potentials. Therefore, managing the psychological consequences of financial crisis is a complex undertaking, and it requires various parties to work together in a timely manner, including healthcare professionals, academicians, students, and the public at large. Having said that, we must keep in mind that all these parties are themselves part of this vicious cycle and have been worn out by the COVID-19 pandemic, which brought everybody down to their knees. Nevertheless, when there is a will, there is a way. So thank you everybody for your contribution, and we wish you a mentally relaxed evening. Thank you.
Thank you all.
Thank you.
Thank you.
All right.
Have a good evening.
Have a good
Have a
one.
good evening.
Have a good one. Bye-bye.
Thank you. Stay healthy. Bye.
Bye.